We are very, very happy to have you because you are our hub to ensure that the great work that Mildmay Uganda is doing through the master plan that we're going to launch, we are able to reach out to the public. We are able to reach out to our partners. We are happy that you work with us throughout the journey of Mildmay Uganda. With us is a team from Mildmay Uganda, and in front we have our Executive Director, Dr. Barbara Mukasa. You are most welcome to this press conference. We have our Board Chair, Professor Luboga Sam. You're most welcome to the press conference. We have Richard Wanyama, Director, Sustainability and Partnerships. You're most welcome, Richard, to the press conference. Within the audience, we have senior managers. Now we're going to be able to proceed with a statement from the Executive Director.
Thank you very much, Tadeo. Thank you very much, members of the press. We value you. And we warmly welcome you to Mildmay, Uganda, the Center of Excellence, and more specifically to the launch of our 30-year master plan that will see our organization evolve into a modern private teaching hospital that is not for profit. We are humbled at the love and strong partnership that you all show Mildmay Uganda. You come here every time we call you. We thank the president of this country, who is also the patron of Mildmay Uganda, for allowing us to have this auspicious occasion, and we're looking forward to hosting him at Mildmay Uganda. The master plan that we launched today will strategically position Mildmay Uganda to contribute towards ending the HIV epidemic in Uganda through the Presidential Fast Track Initiative on HIV and AIDS for this country, and provide strategic economic growth interventions through the care that we give, the training, the education, and the research that we participate in as an organization. Through the master plan, our journey to a fully fledged modern not-for-profit teaching hospital offering quality health care and training as part of our contribution to the national goal of universal access to health care will be achieved. The services and programs are strategically planned to build on the work already done in responding to gaps, constraints, and emerging priorities in healthcare. Mildmay Uganda has evolved over the years into a center of excellence, providing HIV and AIDS care, palliative care, awarding a number of academic programs, diplomas, certificates, and affiliated with many other organizations for degrees in health and healthcare management. Like our healthcare services, the products of our training and education and research are already creating a great impact nationally and in the East African community and beyond. Mildmay Uganda continues to contribute significantly towards ending the HIV and AIDS epidemic, as stipulated in the 5-point plan by the President, launched recently. In 1998, Mildmay Uganda opened its gates to the public for comprehensive HIV and AIDS care, with just over 3,000 children waiting for lifelong saving drugs through PEPFAR in 2004. Today, Mildmay Uganda supports care for over 100,000 people living with HIV/AIDS in the country, and 7,000 of these are children. We have continued to champion the HIV prevention using a family-centered approach and targeting a multi-layered behavioral change in line with societal values and treatment interventions through a number of initiatives, including the DREAMS initiative funded by the US government. Mildmay Uganda continues to offer targeted HIV testing and counseling services to key and priority populations to ensure attainment of our 90-90 goals and effective linkage and treatment to care. With adoption of the test and treat approaches, 98% of adults and adolescents and 100% of all children below 15 years have been enrolled on antiretroviral therapy at Mildmay, Uganda, and supported sites in the districts. Since 2014, Mildmay, Uganda has maintained a 0% new infections among children born to HIV-positive mothers at the facility. And we have worked with the districts to bring down the transmission rate from mother to child from 19% in 2012 to 3% where we work. We thank Honorable Janet Kataha Museveni, the First Lady and Minister of Education and Sport, who is also the EMTCT champion for this country. We continue to register significant success in promoting male involvement, more especially through the services that we offer in the districts. Through our elimination of mother-to-child programs, male networks at male-dominated workplaces, border stages, we have encouraged male testing. We have encouraged male leaders in the community to sensitize men in their communities to go for testing. We have strategically placed male nurses in antenatal clinics to attract men into care, which is a key priority for ending this epidemic. Prioritizing couple counseling and giving results on the same day, as well as targeting key populations and promoting male champions are the other strategies that have led to many successes in that area. We continue to support health facilities in targeted districts to improve availability of essential medicines. This includes training staff, doing mentorship to improve forecasting and quantification, timely ordering and prescription of medicines and commodities. The number of supported sites reporting stockouts of essential medicines and commodities have reduced over time, and we are thankful to our partners, especially the US government, for the support. This has contributed to the great performance in the pharmaceutical sector, and we have worked with all government partners with the Ministry of Health in the lead to achieve a lot. Our laboratory services are a backup system for the national public health laboratories in viral load and early infant diagnosis testing for HIV. We have supported functionality of over 14 laboratory hubs through our laboratory strengthening interventions, and we have supported 10 hubs to attain a star rating score of between 2 and 4. Since 2010 to 2015, over 223 facility laboratories have been given technical support to improve laboratory testing in this country, and we appreciate as donors our support and the Ministry of Health for this work. To strategically improve our contribution to equipping communities to respond effectively to HIV and other national health priorities, our 30-year master plan that we launched today will provide health care through standard and professional service teams as we partner with the government and with our supporters to attain Vision 2040, to contribute to the Vision 2040 agenda for improving health care for the people of Uganda. Thank you for honoring our invitation. We look forward to always hosting you at Mildmay, Uganda, the Center of Excellence for care, prevention, treatment, education, and research.
My name is Zahar Namori. I work with MBS Television. My first question is on the 30-year master plan that will see a hospital that many have known to be a home for persons living with HIV/AIDS also treat other illnesses. How will you be able to strike the balance, and why now? My question number 2 is on the WHO guidelines to increase antenatal visits to 8 instead of 4 for pregnant mothers living with HIV. Are the 8 visits necessary, and will they be able to further the EMTCT fight?
We are a comprehensive program. We have said something about us being a family-centered, but we also are a multidisciplinary approach program. And by that we mean we provide a number of services, and not just the medical consultations. We have rehabilitative services, which include nutritional services. We have psychiatric care, we have dental care, we have psychosocial support care, we have, and in psychosocial support care, we have a team of counselors and social workers who work with our patients, our clients, to support them through the social systems beyond the medical. We have counselors, we have social workers, we have nutritionists, we have nutritional counselors who work with our patients here and in the districts to ensure that the systems around them, including nutritional services, are in place to support them. So our nutritional programs will include counseling and education. They will include emergency food items for people who have severe food shortage. They will include nutritional therapy for severe malnutrition, but they will also include long-term food security initiatives linked to economic strengthening support activities to ensure sustenance. But I would ask Dr. Yvonne Karamaji, who is also the Medical Services Director, to supplement on the nutrition if necessary.
The nutrition of the child depends on what is in the household. So we do family education here, we train families on how to improve their household income. We enroll them in economic strengthening activities, income generating activities. So they are given literacy, they are given startup kits to start economic strengthening activities in their localities. Then we partner with other partners, other citizens in the community. We provide different packages that lead to the nutrition problems in those homes. Some of them support education, some of them support access to gender-based violence services, some of them support access to other microfinance ventures. That way you're able to address nutrition more holistically. In the districts, Dr. Mkasa said we are working with over 200 health facilities. We go and equip those facilities with equipment to measure the nutrition status of children so that these health workers can screen these children early and then support the families. Then we also work with we have an Institute of Health Sciences here. We have courses for health workers to learn more about nutrition. But in Mildmay, we not only train health workers, we still train caregivers and other people. Even the media is welcome to attend these courses.
There are many factors that affect adherence. You'll be glad to know that the number one factor that affects adherence is the success of antiretroviral therapy. These people feel good, they recover, they look healthy. They then have to wonder, do I need to continue when I'm not sick? And therefore, the family-centered approach here is credited for going deep in patient education to make them understand that it is suppression, that feeling good is what we aim for, so that they can be able to work, get jobs, and look after themselves, be productive again. And when they are productive again, they are more efficient at addressing their nutritional needs than if they are poorly and we are just supplementing them from our meager resources.
In Uganda, most women turn up the majority turn up for their first antenatal visit at 5 months, and in our pregnancy, 9 months, right? So that is quite late. So if we increase to 8, we are trying to increase the awareness of the importance of having a health visit while you're pregnant. And if a lady is HIV positive, we want to make sure that in the last trimester, which is the last 3 months of the pregnancy, we are monitoring the viral load, the amount of virus in the mother's bloodstream, so that we eliminate all opportunity of this virus crossing to the newborn baby. So if you only have 4 visits and people come late, we will get most of these mothers late. And And here we make sure that mothers come early, those already in care, and that's why we've had the success of all the mothers in our care have not been transmitting HIV to their newborn babies. So we believe if we spread it out as a country to 8 visits, one on average will have at least a monthly visit with the health worker, so that we monitor the viral load better for this pregnant mother. By the time they get to that last trimester, we have suppressed their virus, and that way they'll give birth to a healthy baby, but also be healthy after that experience. So we think it's good. Secondly, with mothers who have HIV, we have what we call family support groups. So you want them to also attend, and these family support groups are monthly. So increasing the visits to 8 will still help them within already the service package we are giving. So they'll be able to come for their family support groups, get an antenatal checkup, we check their virus status. For those who are not suppressed, we then give intensive adherence counseling to make sure that by the time they deliver, they are suppressed. So the more visits will be conducive for us to follow up their outcomes better.
In the day-to-day, where we approach our business as Mildmay, we then, to operationalize it, we then wait for the national position from the Ministry of Health, because then the national position, the national guidance, put that WHO proposal into the national development context. Because 4 visits, you take them to 8 visits, they have development and economic issues at the household level. So the national planning framework then gets that global recommendation and puts it into the national context. And then with us, as one of the leading players in the country, then we follow what has been contextualized. Yeah.
Thank you very much. Second bunch of questions.
You were saying that since 2014, Mildmay has maintained a 0% of new infections among the children. If you don't mind, can you please share with us how have you been able to achieve this, leaving aside the issue of visitations that the mother come to the hospital, and what is the number of the mothers that we are talking about here since the period?
What do we do to eliminate mother-to-child intervention? This is a national program. There are a number of interventions, Eva, that Mildmay and others in the fight against HIV will focus on. These interventions begin, like you have rightly mentioned, from before you become pregnant. Before you become pregnant, the first, if I am not HIV positive, I cannot perhaps pass on HIV to an unborn baby. So the interventions start before I get pregnant. We will have programs for young women, young girls in school, out of school, to prevent them getting HIV in the first place. And we have a number of initiatives, including the DREAMS initiative, where we are making sure that girls and young women stay HIV negative through a number of interventions that involve the circles around them, the men or the males that they interact with, their teachers, their parents, their school peers. A number of interventions are being implemented in this country to make sure that girls stay HIV negative and do not get pregnant before they are ready to be pregnant. Now, after that, you may actually get a girl being pregnant. When she is pregnant, we talk about the antenatal visits. Like Richard has mentioned, this we implement in the context of the national policies. At an antenatal visit, there will be a lot of education. There will be a lot of support for this young lady to make sure that she understands the responsibility that she has gotten into. There will be interventions that there will be messages for those in marriage. There will be messages for those in different contexts to make sure that we are supporting them through the pregnancy. If I were HIV positive, it would mean there are certain drugs that I need to be on, including the life-saving antiretroviral treatments that I would take. Adherence is something we've already mentioned, making sure that I'm taking my drugs on time, at the right time, the right dosage, and all those things are what we do at an antenatal visit, including the routines around making sure both my health and the health of the baby are looked after. Then there are things that we will do during delivery, including making sure that there is as little blood or blood contact or fluid contact between the baby and the mother, and the medical details of that perhaps is what I will not go into. But that's what we train doctors, that's what we train midwives, that's what we train nurses, or anybody who is in attendance to the child will go through. After that, there are things we will do with the mother, advice around breastfeeding. We, as a country, have adopted a policy of exclusive breastfeeding in the context of HIV and AIDS for 6 months for the mothers. This is to reduce the likelihood, again, of passing on infection, because it is possible that through the delivery process, through the antenatal period, you do not pass on HIV, and then after the child is born, HIV is passed on to the baby. So there is a number of issues. There is a national policy to guide us on each of these issues. There are contextual issues that we look after through our network through our multidisciplinary teams to make sure that we get these outcomes. And yes, we have been able to sustain a 0% transmission rate here and in some of the facilities where we work for HIV transmission. Here at Mildmay, Uganda, we provide antenatal services, but most of the work that we do is in the districts that we support. On HIV resistance, again, HIV resistance is a problem that is growing, but is not yet out of control. There's a lot that we can do, both for transmission to children, but also for resistance. The key factor is in adherence to our treatment. So a lot of work goes into preparing our patients or our clients before they start lifelong treatment. The goal is to stay on treatment and to take it properly in the right doses throughout the period after the diagnosis. You're aware the national policy has now changed. We test and start treatment. We do not wait, and we then monitor your response to treatment. There are very few cases that could have resistant infection right from the start, but a lot of the resistance that we get is because perhaps we haven't stayed or taken on the treatment as we ought. So the number of patients on second-line treatment for us who are a tertiary referral center, older than many of the programs, will have around 11%, 8 to 11% of our patients on second-line treatment, and just a few patients, 10 to 11 patients at any one time on third-time treatment. Resistance is, or difficulties with adherence will be more common in the younger patients, the children, because they depend on a number of factors beyond them to adhere to their treatment. But we have supported our patients, but also our districts, to maintain a very good suppression, viral load suppression results, way above between 92 to 95% suppression rates, and in some pockets 98% suppression rates, as monitored from our viral load testing. The country has rolled out a national viral load testing program. We are implementing that rollout diligently. We are supporting our districts, the districts where we work, and our patients to understand the importance of viral load monitoring, and we are seeing great results as a country, and are excited about what has been done, even as we challenge ourselves to do more.
And if press could commit themselves to promoting prevention and promoting adherence, the problem of resistance will be kept at a minimum. Because really we cannot win this scourge if we have too much HIV resistance. So we must prevent resistance, and we are relying on you to help.
Okay. And now yes, if you have a question.
It's Paul from the Daily Monitor. I wanted to ask you on the number of clients who are positive countrywide, how many of these are adolescent girls? And why do this, the recent report showed that the numbers when it comes to adolescent girls, it's increasing or something. And why is that so?
Okay.
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 Another question?
Yes, adolescent girls is a very special group. Paul, for Mildmay, Uganda. Mildmay, Uganda started out in 1998, perhaps as the first free HIV program for children. And therefore, by 2004, when we got the first free ARVs coming through PEPFAR, we had over 3,000 children waiting for the life-saving treatment. Many of those children have grown up to be adolescents and even adults now. And we have seen great successes, and we know that this can happen. At Mildmay, Uganda, 10 to 11% of all the patients in our care will be adolescents. 60% of who we care for, between 60 and 50%, because we're doing a lot of interventions now to attract men and boys into care. Between 50 to 60% of all those in our care will be females. So we have greatly focused on adolescent girls. I have talked about a program where we're working with our partners, PEPFAR through CDC, to recruit over 40,000 girls and work with them and their systems, or the systems and their families around them, to make sure they stay HIV negative over the next 2 years as a proof of concept that this can be done. Why is it adolescence? I think adolescence is a challenging time for many of us. I hope for you as well, Paul, so you will understand what I mean. It is a time that you're transitioning from a child into an adult, and you're dealing with a lot of factors that can confound your care. Many adolescent girls or young people will discover their HIV status around 10, 11. Some will have been born HIV positive, but only disclosed to later in their lives, 10, 11, 12, depending on their individual circumstance. So there is a lot to deal with. But at the same time, you're dealing with sex and sexuality issues, which are very important at that time. You are challenged. I have sat in a clinic room, and an adolescent girl has asked me, "Doctor, you are asking me to do 1, 2, 3 for reproductive health care. But the thing that I would have feared most, I have. So how do I deal with that?" And many times you don't necessarily know the answers. We all approach life from a different perspective, and it is understanding those different perspectives for each and every patient that we can give an individualized care. That is the task that we face. But we try through a number of interventions. We've talked about a multidisciplinary team. We have child-specific counseling. Mildmay Uganda runs child counseling programs that will identify specific adolescent support issues, and we will have emphasis on them. But the world over, the adolescent category is the group that for which HIV-related deaths are increasing, and the world is focusing on this.